resistance, and efficacy, you calculate that between 15 and 30% of patients with schizophrenia ought to be on clozapine. And, every major industrialized country is within that range, except for the United States. We are tied with Malaysia in portion of patients with schizophrenia who are on clozapine. This is remarkable and a little bizarre, in my view. So to underscore the weirdness, in my view, as to why the weirdness about why so few people are on clozapine, I will direct you to this graph. This is an estimate of effect size of various antipsychotic drugs. And you see that clozapine in the blue bar has an effect size of 0.9, which is in a different category of efficacy compared to every other antipsychotic drug that was included in this analysis. So it's clearly the most effective drug for efficacy, yet is in this country among the most unused of medicines. Another point for why we should think about clozapine as a population of prescribers we should think of clozapine more frequently than apparently we do, is going back to the suicide reduction. So this is a study in which they looked at suicidality, suicides or suicide attempts among people with schizophrenia. In the dark blue bar, all people with schizophrenia. If you look at those that receive clozapine in the light blue, you'll find that suicide is reduced to pretty much exactly the suicidality rate in the general population. So being on clozapine in this study reduced suicide risk to as if you didn't have schizophrenia. So this is a remarkable reduction of suicide. In fact, if you calculate the number of people, the number of cases of suicide that we could reduce if we were to utilize clozapine in 15% of people with schizophrenia, you would find that you'll save thousands of lives in Ohio during the course of an illness and tens of thousands of lives in the country at large if we were to simply move our clozapine utilization up to the levels that exist, say, in India. So we have the world's most effective medicine for schizophrenia within the world's most elaborate and costly medical system, yet we use it almost never. Why is this so? I don't know that anybody has a really super good answer, but I'll put out some potential suggestions. One, the fact that it has these special blood draw requirements oftentimes is off-putting to people. I don't think that accounts for why the US is so bad compared to, say, England, because every country on the list has the same or very similar blood draw requirements. From what I hear from clinicians, there seem to be inadequate support within billing infrastructures or clinic infrastructures to allow it. So how does a patient who may not have transportation get to a laboratory, and where does the clinician find the time to do all these extra pieces of paper and attending to these details that are necessary for clozapine management? And the curious fact of psychiatric training is that there's actually no specific requirement that to graduate from a psychiatry resident, you have to have ever prescribed clozapine for anybody. And this is also the same for nurse practitioners entering practice. So it's quite possible that somebody can go through a psychiatric training program and never have registered with the clozapine registration system and never have prescribed clozapine to anybody. So if you don't have supervised experience in clozapine management, it makes a clinician in the field very hesitant, or places another barrier to prescribing medication that has so many, that has an aura of special risk around it. Related to another factor is that there is no longer any drug company that actively promotes clozapine. Clozapine lost its patent protection in around the year 2000 or 1998. So in the late 90s, let's say, it lost its patent protection. The manufacturer at the time, Sandoz, basically stopped marketing it ahead of its patent expiration. And around that time, risperidone was on the market. And then after that, other second-generation drugs came about. And at that time, I was in training at that time, so I remember all these things very well. The various manufacturers of the newest, awesome second-generation atypical drugs would say This is an atypical drug similar to clozapine. In fact, I was at a meeting sponsored by Pfizer in which they said flat out that, look, here's a clinical study which shows that treatment-resistant patients on Geodon do as well as patients with clozapine. So there was actually very active undercutting of the competition with a drug which was didn't have blood draw requirements. So the pharmaceutical marketing efforts of the late 90s and early 2000s really drove a nail into it, as well as the fact that there was no special program within psychiatry training or nurse practitioner training to mandate that clinicians will gain experience in a drug that doesn't have this corporate backing. And another problem is that we as a field continue to ignore what was pretty strongly felt to be the case decades ago, that when we say schizophrenia, we're not talking about just one disease. So there are actually many pathways to schizophrenia. Some of them have to do with dopamine and some of them don't. Therefore, some schizophrenias will respond to standard antipsychotic drugs and others simply don't. Not acknowledging that there are different schizophrenias is a problem for clinicians in motivating them to use clozapine. So to the topic of many diseases with schizophrenia, the majority clearly have something to do with excessive signaling of dopamine. I think you can think of these as dopamine psychosis or dopamine hyperactivity psychoses. But a lot of biomarker studies, some of which we've talked about in earlier SC consult didactics, also show that there are many other highly relevant neurochemical pathways to the schizophrenia symptom cluster. And many of these pathways have really nothing to do with dopamine. Biomarkers of dopamine turnover are flat out normal in many cases of treatment resistance. So the data are really point to the existence of a non-dopamine category of schizophrenia. And dopamine drugs, therefore, don't work on a disease that has nothing to do with dopamine. But not appreciating that, you wind up with this situation. On the left, we have the view of medication non-response in a one schizophrenia model. So in this view, medication non-response is seen as the disease process is stronger or more powerful than the medication can manage. So this view of schizophrenia and treatment resistance oftentimes leads clinicians to increase the dose to perhaps 2 or 3 times what are on label, or to add multiple antipsychotic drugs within the same category. The idea that if we just push harder against this disease with these drugs, it will eventually yield. In my world, which is consulting with complex cases, this is rarely the case. What I see and what the data point to is that we're looking at different diseases. So when treatment resistance, so in a multi-disease world, as illustrated on the right, when a medication isn't working, it's because it's in the wrong game. You're trying to use a dopamine blocking drug to treat a disease which has to do with glutamate or with inflammation or with some other process besides dopamine. But we don't have an active, this alternate view doesn't have as many proponents in the medical literature, so it's largely unknown to a lot of clinicians in the field. Another reason to consider clozapine is that, ironically, studies show that clinicians are very hesitant and have a lot of negativity toward clozapine, whereas patients who are on clozapine actually have a lot more favorable views of it than the clinicians do. Studies were done to actually survey clozapine users, and of people who use clozapine, more than 80% say that it was better than anything they've tried and they want to stay on it, even in the paper, despite the fact that many of them would have at least one side effect. So patients, even though having side effect, would still vote in droves to continue with that drug. And why? Because overwhelming, I mean, these are the reasons why they like clozapine. So notably, I mean, these are the things that patients care about. It's easier to live. I get my life back. Easier to mix with people, to socialize, to be independent. Clozapine offers a form of recovery that actually matters to people. So when contemplating moving somebody to clozapine, I encourage clinicians to perhaps put their reservations a little bit to the side and think about it from what a patient might say, who stands to benefit from it in these fashions. So to summarize, why to use clozapine? Because it is effective in this form of illness called treatment-resistant schizophrenia. It has far and away the best evidence. It being effective at reducing psychotic symptoms can shorten the duration of psychosis, and shortening psychosis will translate into higher quality life over the course of somebody's life, higher quality of life over the course of a lifespan. It reduces suicide, and therefore it saves lives. And as much as people try, as much as pharmacologists like me will try to figure out ways to help somebody who needs to be on clozapine that can't be on clozapine, as much as we try, it's really difficult to come up with any combination of medicines which can match clozapine's efficacy in terms of degree of response and reliability of response. So there's just really no substitute for it, despite what perhaps managed care companies might lead you to believe, or what you might read in some of the journals that are generally not peer-reviewed. So those are comments on clozapine rationale. As I said, next week we'll talk about the neutropenia question.